To deliver good. Welcome to On Call with the Prairie Doc, where we work to deliver good science-based medical information with no waiting rooms nor any copay. I'm Jay VanDuch. Dr. Holm is away on assignment today. The heart beats over 115,000 times a day. It is a rhythm of life that we share with all animals. It's vital for every animal from an earthworm to a pachyderm. And if that rhythm is interrupted, bad things can happen. Okay, let's take a look at this week's Prairie Doc quiz question. It's a true or false one, so you got a 50-50 chance, better than that lottery thing. The irregular rhythm of atrial fibrillation, or AFib, puts the individual at increased risk for stroke, and therefore blood thinners are almost always indicated. True or false? True or false? Viewers who call in with the correct answer will be entered into a drawing for a signed copy of A Picture of Health. This is a book that was written by Dr. Holm with accompanying photography by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only get 10 minutes to get your answer in. We will answer your medical questions about the heart as they're called in or sent to us via Facebook or email. Call in your questions to 1-888-376-6225 or send us an email. Joining me tonight is Dr. Tarik Mahruos and Dr. Jonathon Adams of North Central Heart in Sioux Falls. Dr. Mahruos, let's talk a little bit about your background. Where did you go to school and study, and what brought you to Sioux Falls?
I'm an interventional cardiologist, which means I did cardiology training. I did all my training in Omaha, Nebraska. I met my wife in Omaha. We moved to Sioux Falls. She's from the Sioux Falls area. And so now I generally specialize in general cardiology with interventional cardiology, meaning I tend to treat heart attacks. We do things like angiograms and coronary stents.
So are you connected to like an emergency room situation, or are you like somebody has a problem and they get them through that and then you help him?
Well, in my practice, I do just about any type of situation. I do clinic practice. If I'm on call for our hospital. I see patients in the emergency room, acute heart attacks, preventative care. It's any patient that has basically cardiac issues that I can help them with, I can help them with.
Great, great. Dr. Adams, what's a little bit about your background? Where did you go to school and what brought you here?
Well, I grew up in Yankton, South Dakota, and went to South Dakota State University here in Brookings. I actually majored in electrical engineering, then decided to go to medical school. I went to USD Medical School down in Vermilion, and then I knew I wanted to be a cardiologist when I was in medical school, and I went with internal medicine training at Mayo Clinic over in Rochester, Minnesota. I went to cardiology fellowship at Mayo Clinic down in Scottsdale, Arizona, and then I did an additional couple of years in specifically heart rhythm disorders at Sanford University out in Palo Alto, California. And what got me interested in heart rhythm disorders, well, you know, I have this background in electrical engineering dating back to Brookings, and a lot of the stuff that we do is sort of like kind of the merger between, you know, devices and humans, and there's a lot of that kind of tech stuff involved in the specialty that I do.
Yeah, well, the human body is kind of like mechanical and soft tissue and all this kind of stuff all mixed together. You know,
Yeah, exactly.
It has to work in the rhythm, which of course is what our whole show is about. Earlier we were talking, you do stint work is a big part of what you do, inserting stents. Tell us first a little bit what stints are and why a person would get one.
Okay. Coronary stents are a little mesh that is inserted into the artery of the heart. It's generally indicated if somebody's having chest pain that can be due to limited blood flow to the artery in the heart, or if they're having a heart attack, we can abort a heart attack, reestablish blood flow, and oftentimes save a life.
Great. Now, has this replaced open heart surgery generally, or what's the relationship between that? Because that's kind of what replacing a vein is about too, isn't it?
Sure. Coronary stents are implanted through the arteries, either through the leg artery or through the wrist artery. It's less invasive than open heart surgery. I don't think it's ever going to completely replace bypass surgery. They each have their own individual role. Certain situations would require bypass. It certainly has taken away situations where bypass would have been done in the past as technology has improved to this point.
Okay, thanks. Dr. Adams, when do you see a patient then? At what point in this whole mix of things do you run into someone?
Well, so we see patients actually of all ages. You know, we see patients that are young kids. You know, I mean, typically once you're out of the pediatric group, you know, if you're a teenager and above, you know, we might see patients like that because young people often have problems with heart rates that are too fast. They might feel lightheaded. They might pass out. We'll see them. As you get older, if you have heart attacks, people develop other rhythm disorders that can be life-threatening. In some cases, we put in devices. Generally, as people also get older, they might have a heart rate that's too slow. They might need a pacemaker. So we can see patients of all ages. We see a lot of them in the clinic, but a lot of times patients come into the hospital or the emergency room feeling weak, lightheaded, dizzy, or having some rapid heart rate, and they call us to come and see them there as well.
So a pacemaker could be something you plan for, you know, that, oh, well, you know, we need to get one in here to get things going, or it could be something that, oh my gosh, this person, we need to do this like today.
Oh yeah, absolutely. It could go either way. I mean, there's depending on why your heart rate is too slow, kind of dictates the urgency of putting in the device. We do have temporary pacing systems as well, where you just put in a catheter with an electrode at the tip, and there's an external generator that we can hook up. So say a patient came in and their heart rate was too slow and it was simply due to medication, we could put the temporary pacing catheter in and then stop the medication, see if the heart rate recovers.
Great. You brought some pacemakers in, I see, and let's look at these real quickly if we can. So I think I have the right order here. This was the first one that you were talking about. And if you want to talk about what this one is?
So that right there is a standard pacemaker. And really what this is down in the bottom here, that contains a battery and a little microchip. And this clear part at the top has slots for where the wires plug into the device.
Right, the wires come in.
Yeah.
Now this one is a little bit bigger, quite a bit, but it's different. How is this one different?
So that's a defibrillator, okay? And all defibrillators can function as pacemakers. But the reason that this is bigger is because the purpose of a defibrillator is to shock somebody's heart if they have a rapid rhythm that could be life-threatening. So in this device, there's a microchip, a bigger battery, and a capacitor, and the capacitor is what charges up and delivers the shock.
So, and that's all this one does is defibrillate. It doesn't keep a pace.
No, it does. It functions also as a pacemaker. It can do everything a pacemaker does, but it also can shock your heart if your heart rate's.
Okay, and this is the fancy BMW M3 of the pacemakers here.
Yeah, so to speak. So this one here is a special case, and that's what we call a biventricular defibrillator. There's also biventricular pacemakers, but this will try to pace your heart in such a way that it can resynchronize how your heart squeezes to hopefully improve how well the heart functions. And it also functions as a defibrillator. So this device is intended to pace your heart 100% of the time on purpose.
Okay. So how often does a person get this? What kind of rate? And then how many of them do you put in a say a year?
So that's a good question. I think last year, we probably each of us do somewhere between 50 and 100 of these a year. I tend to break it down between the different devices when I look at how many I do, but it's quite a few. The vast majority of these defibrillators that we put in are put in for what we call primary prevention. And primary prevention is someone who is at risk to die from a fatal rhythm problem. They have risk factors for it. Their heart's weak. And it's weak despite having stents or having bypass surgery. They're on all the right medicine and their heart's still not getting stronger. They're at risk to die from a sudden arrhythmia. We put one of these in to protect them from that, okay? The minority of patients are patients that come in and have survived out of hospital cardiac arrest, and we would put them this kind of device in that patient as well.
And what would make it, does it happen often that a person starts with just the basic one and then down the road you say, oh, we need to upgrade it? Is that a common event?
It does happen. It's not that common, but it does happen that patients have had a pacemaker because they've had a heart rate that's too slow for quite some time. Then over time they have a heart attack or something happens where their heart gets weak, and then we have to upgrade them to a defibrillator.
Great. Well, we happen to have a little story about somebody whose heart rate was having problems. If you've never heard of Wolff-Parkinson-White syndrome, you're not alone. Emil Redfish did not know what he had until he was diagnosed with this rare disease.
I've had lifelong affliction with Wolff-Parkinson-White, which wasn't diagnosed till I was in my 20s, and was experiencing some rapid heartbeats or where you could feel your heartbeat, and happened to be working with the internal medicine doctor that made the diagnosis for me. What, in my experience, is there's many ramifications or different kinds of Wolff-Parkinson-White's the way it works, but basically it's the electricity that travels through the heart from the top to the bottom takes a different path than it's supposed to at times, and so it makes the heart beat, and I call it when my heart flippy flops because I can feel it. You go in and I go in and out of it. For many years it was like maybe an episode every 3-4 years, but lately it's becoming more often. The thing about it is the longer it lasts, the more, because your heart isn't functioning just right, it's not pumping blood the way it's supposed to be, so you can, when it does revert back to its normal beat, that you're really tired, and it takes a lot out of you because your pump just isn't working right, so it's not exchanging oxygen in the lungs and stuff like that the way it's supposed to be. I've always, with this, I've kind of put things together just because what I do of trying to figure out what triggers it. And lately it's been triggered because I turned diabetic about 4 or 5 years ago, and that's when I start having more episodes. I've kind of equated it that when I start feeling this, my blood sugar is either too low or too high. So I check and follow. I have rheumatoid arthritis, so it's hard for me anymore to exercise. And one of the things we've found is a trigger to, like I said, the trigger is that we found triggers with the diabetic medicine. Unfortunately, the base radical in the diabetes medicine is also in the arthritis medication. So it's another one of those medication balances. So basically, when I get into problems, I sit, or I just relax, lay down, sit, try to find a television program or something just to not do much more than that. And usually that'll pull me out of it rather than trying to force it with medications.
So we know that less than 3 people in 1,000 generally get this syndrome, but have you seen anybody with this?
The WPW, as you mentioned, it's not very common. I primarily don't get electrical problems, but occasionally I'll see a patient, they get sent to me for an abnormal EKG. They get a EKG in their clinic and it's abnormal. I look at it and I say, well, that looks like the WPW pattern on an EKG. The syndrome is more of a clinical syndrome with the EKG and then symptoms. So when I see this type of pattern, you have to figure out what kind of symptoms they're having. Do they need more evaluation? And when it comes to evaluation, I usually send them to my rhythm specialist, Dr. Adams, because that is what he does.
And then what do?
Well, sir, I'm going to use your...
Sure, yep, there we go. You want one of the hearts?
Yeah, I'll put that
Yep.
first heart up here.
There you go.
So I'll show you kind of how a heart is supposed to work to begin with. And so your heart's supposed to kind of start beating from up in this area, and then there's a wavefront that kind of travels across, and it goes through a middle spot right here, and then conducts down to the heart muscle that way. Well, Wolff Parkinson White patients have, and the most common spot's going to be kind of like over in this area, have a little connection of muscle that connects directly from the atrium, from the upper chamber, I should say, atrium is the upper chamber, directly from the upper chamber to the lower chamber without any delay. It just conducts directly. And so what will happen in these patients is they'll have some conduction going here and then some conduction going here. And that's what creates that abnormal thing on an EKG that Dr. Mahruos was referring to. And so what do? Well, we interview the patient and talk to them and get a sense of what their symptoms are and get a sense of what their risk factors are, look at all their old EKGs, that kind of thing. But if we're unsure, we can do a special procedure called an electrophysiology study, and we can go in and we can figure out how fast does this specific spot conduct, and what is the patient's risk of dying suddenly from this. Fortunately, the risk of dying suddenly from Wolff Parkinson White is really quite low, but if we find on the electrophysiology study that the risk could be elevated, or if they're having a lot of symptoms due to a rapid heart rate, then we can put a special catheter up to the heart that has an electrode on the tip that can cauterize this spot, and we can map that out and get rid of that and pretty much cure the disease, which is really kind of nice.
So just a little kind of a zap, and you kill that part of the muscle so that it doesn't...
Exactly. Yeah.
Cool. We got a couple of questions we can go to here. Let's try this first. Let's go to this. An 88-year-old woman from Sioux Falls has heart arrhythmia for a long time. What should she do to straighten or fix the condition?
I'll take that, I guess, since I'm the arrhythmia specialist. That's a difficult one. It depends on what your arrhythmia is, and it depends a lot on what we know about your heart to begin with. You'd have to actually come in and be evaluated, go to your doctor. Generally, what we have to do is record the arrhythmia, like be recording your heart EKG or some kind of rhythm strip when you're having the symptom and having the arrhythmia, and define which one it is, and based on that we can tell you, what is the significance of that, what should you do about that. A
60-year-old man from Dakota, he says, let's explain congestive heart failure. You want to run with that, Dr.
Yeah, absolutely.
Mahruos?
So congestive heart failure, we usually say, is a clinical diagnosis. It's based on the fact that your body's not able to keep up with its demands. So if you want to perform at a certain level and your heart just isn't keeping up, you can develop congestive heart failure, whether it's your heart's weak, your heart's stiff, whether it's the right side of the heart, the left side of the heart. There's many different forms of congestive heart failure, but it all relates to the same type of symptoms: more shortness of breath, fluid retention, fluid on the lungs. Again, many different causes. A lot of times have some of the similar symptoms. To give you more definitive answers, you need more additional testing to come up with a better answer. But it is a very common problem with many different causes.
If we know the term congestion, this time of year especially we hear about it. What's the congestive part of the heart? When we say congestive, what are we really talking about?
Generally, the medical term would be something pulmonary edema, so you get fluid on the lungs, which makes you short of breath, particularly if you're laying down at night, you feel like you have to sit up. That's orthopnea is the medical term. But fluid on the lungs, meaning your heart just can't pump the fluid forward, so it's backing up into your lungs.
So what's the normal treatment for that sort of thing?
It depends on the cause. Mm-hmm. So if it's because your muscle's not getting enough blood flow, you treat the blood flow. If it's because of high blood pressure, you lower the blood pressure, slow the heart rate down. If it's because of a slow heart rate, you speed it up. If it's because of things like sleep apnea, lung disease, coronary disease, again, looking at the cause, you treat the underlying cause to try to reduce the condition, and then also treat the symptoms with water pills and things of that nature.
And survival rate, if you get, what's the survival rate, or is it pretty good then once you get treatment going?
Well, there's no cure for congestive heart failure, so once you have it, you'll always have it. There's just different stages of it, and there's different classes of heart failure based on your symptoms. It is one of the most common causes of mortality in the United States, whether it's because of a weak heart or what we call the stiff heart. But once it's identified, it should be treated aggressively to improve mortality.
And whatever treatment you start, then you're going to need to do that for life, essentially.
Essentially.
Yeah. Well, does it always get worse?
I describe congestive heart failure as like high blood pressure. Mm-hmm. Once you have it, you're essentially going to have it. We treat it. We try to manage the symptoms, reduce the flare-ups. Mm-hmm. It's a chronic problem that you'll have flare-ups over time. We try to minimize the number of flare-ups and the fact that we're trying to keep you out of the hospital from that.
Are there exercise or nutritional things you might be able to do for that, do you think? Or?
Sometimes I always tell patients to exercise as much as they can tolerate. Mm-hmm. Often your exercise tolerance is not very good with congestive heart failure. The other thing that I'd add to what Dr. Mahruos already said is that if you get really advanced congestive heart failure, you can have advanced therapies done, not in Sioux Falls, but at like Mayo Clinic or University of Minnesota, where you can have a device implanted called an LVAD. It's a left ventricular assist device that kind of takes over and does the heart's pumping for it. You remember Dick Cheney had this procedure done, and he was wearing vests because that's where the batteries went, was in his vest pockets. And then later on, he had a transplant, and that would have been the cure for his congestive heart failure. It would have been of course, he traded that congestive heart failure set of medications for his transplant medications. But so we do have some therapies that are absolutely life-saving for very advanced congestive heart failure. Otherwise, we manage it. Other things that we do, I should say, if you have a weak heart, particularly the left lower chamber of the heart, that's when we use these defibrillator devices. Mm-hmm. And this particular device, this device that's intended to sort of resynchronize the way your heart pumps, that's used in specific certain cases of congestive heart failure where the cause of the heart failure may actually be the way the conduction system is working in your heart. And sometimes I've seen this make dramatic changes in some patients. I had one patient where we talk about, in cardiology, we talk about this number called the ejection fraction. Mm-hmm. And what that is the heart fills up with blood and then it squeezes out some percentage of it. And normal is more than 55%. And so this particular patient had an ejection fraction down less than 20%. It was like 15%. And it was not due to blockages in the arteries or anything that was obviously reversible. And despite medicine, his heart remained very, very weak, and we put in one of these devices, and it got it up to like 50%. It was very, very dramatic. That happens.
Must have been a huge life-changing event for him to all of a sudden get that much improvement.
Yeah, it was pretty dramatic. It doesn't happen very often. The average improvement with these pacing devices in that 10 to 12% for your ejection fraction, but he was very dramatic.
We got a lot of questions coming in. This is, as I said earlier, going to be popular. So let's go. A 70-year-old woman from Centerville has AFib. What anticoagulant do you guys recommend? Warfarin or one of the other ones, or do you try to start out with something simple and build, or what procedures do you usually recommend?
Well, in a 70-year-old woman, I'll take that one because I see a lot of atrial fibrillation. A 70-year-old woman with atrial fibrillation would need an anticoagulant for sure, and I tell them that it really doesn't matter which one you use as long as you use an anticoagulant and you take it and you don't and you're compliant with it. There's advantages and disadvantages. There's really 5 different options on the market right now. Those are Coumadin or warfarin. One's called Pradaxa, Xarelto, Eliquis, or Saveza. Some of them are twice a day. Some of them are once a day. Some of all the new drugs, and in other words, the ones that are not warfarin or Coumadin, all the newer drugs were tested against Coumadin. Some of them are a little bit better at reducing your risk of stroke than Coumadin, and that's ever so slightly better than Coumadin. And some of them are the same or equivalent to Coumadin. Okay, some of them have a little bit higher risk of bleeding in the GI tract compared to Coumadin. Pretty much all of them are the same or lower for risk of bleeding in the brain compared to Coumadin. The only drugs on the market that are reversible, where we have antidotes for them at this point in time, are Coumadin and Pradaxa. There is the antidote for all the other ones is actively being trialed right now, and we'll probably expect that before the end of the year. So short answer to the question is you should be on one of them. It doesn't matter. Whichever one you can take, whichever one you can afford. Patients on Medicare these days, a lot of times their health insurance doesn't cover the newer agents, and they can become very, very expensive, cost prohibitive.
And warfarin is more?
Warfarin's been around for a long, long time.
Yeah.
It was actually developed in, like at the University of Wisconsin. It stands for Wisconsin Alumni Research Foundation. Yeah. And it kind of discovered, like accidentally, it's sort of like the penicillin story, but it's been around for ages. The problem with it is you have to measure this value called an INR. It tells you how thin your blood is, and you check it frequently. And some people are easier to control than others, and there's a lot of interactions with Coumadin. Your diet has to be fairly consistent to take Coumadin, but it is inexpensive, and it is once a day, and it's reversible.
Great. Another question. A 64-year-old woman from Brookings has a concern about a heart that seems to be beating faster and faster. And with a related one, we got a call from Mobridge, who wonders just how does a high rate of heartbeat kill somebody? Why would that happen?
I can touch on the first part. The concern that the heart rate seems to be beating faster, I guess that would bring into questions, is it faster at rest? Is it faster with activity? Is it being triggered by something? How fast is it going? If all of a sudden it just starts beating for no apparent reason, there may be some underlying rhythm abnormality. If it's just beating faster, sometimes deconditioning can make your heart beat faster over time. How high of a heart rate would kill someone? Too fast for your heart to pump blood efficiently. I mean, you can get your heart rate up over 200 in a young person, and that's just fine. I would suppose close to 250 or 300 would probably be prohibitory. I guess Dr. Adams could probably answer that question.
Yeah, I was going to say the same thing. I mean, I've seen young patients tolerate heart rates, 200, 220. If the origin of the heart rate, the fast heart rate, is from the upper chamber, if it's driven by the upper chambers of your heart, not the lower chambers of your heart. But once you get in that 250 to 300 range, people don't tolerate that very well. And that's the lower chamber of your heart beating that fast. The upper chamber of your heart, when people have this rhythm called atrial fibrillation, if you look and you measure how fast is the upper chamber of the heart beating, it's beating about 300 plus beats a minute, whereas the lower chamber might be beating 120 or even less than 100 beats a minute.
So it's not really working together at all.
Yeah, remember, we can go back to this diagram here. Remember, I was telling you that there's this little spot in the middle where the heart conducts electricity through this middle thing. Well, this acts sort of almost like a governor on your heart, on your engine, so to speak. And the faster this upper chamber beats, the slower this conducts to protect the lower chambers from beating too fast. Because you can imagine if this is the chamber that pumps blood out to your body, and if that's beating 300 beats a minute, it doesn't have time to fill with blood, and then you can't pump blood out to your body effectively, and that's when it can be life-threatening.
Great. So what advice would you give this woman then? Who does she need to go see to find out why her heart's beating like that?
I would start by going to see your primary doctor and probably get an EKG. And sometimes you can wear a heart monitor that actually records every heartbeat over a 24 or 48-hour period. And then you can actually say, here's what your heart rate's actually beating. Sometimes it feels fast and it's really not. And sometimes it feels fast because it is. And to tell you what you have to document what's the rhythm to give better information and more answers.
And I think this was what we talked about before. 85-year-old from Aberdeen wants to explain cardioversion. That's what we talked about before, wasn't it?
Yeah, so cardioversion is, it depends on why you're being cardioverted, but it basically means that you basically stop the heart intentionally and allow it to restart on its own. It's sort of like rebooting your computer, so to speak. And so oftentimes, like I did a cardioversion today on a patient who had atrial fibrillation where the upper chamber of the heart was beating too fast, and we sedated the patient, and you put patches on the chest, and once they're asleep, then you can shock the heart, and then it stops it temporarily for a second or two, and then it starts back on its own. And Dr. Mahruos and I both, all cardiologists do cardioversion.
Does it work pretty well, and how long does that kind of treatment usually last for somebody? Do they need to come back later again often, or is it kind of like, oh, do it once and you're okay?
Yeah. Well, usually they end up coming back.
Yeah.
So a lot of times the reason why would we do a cardioversion? So for someone with atrial fibrillation, I'm trying to cardiovert the patient to get them back to normal rhythm to see, do they feel the atrial fibrillation? Do they feel better when they're in normal rhythm? Is there a change in symptoms? The other reason why you might do it is that their heart's just too fast and they're not feeling well, or their blood pressure's low and the medicine isn't working, so you do a cardioversion. All right, but generally, if you do it for atrial fibrillation, it will come back at some point. You never know. So you do wanting to see, and if it comes back despite no medicine, sometimes we put people on medicine and then cardivert them again and the medicines to try to maintain that normal rhythm.
Great. Via email, 56-year-old woman. What do you, both of you guys, think of blood thinners for the rest of the patient's life after a heart attack? Are there concerns about staying on blood thinners that long?
So when people use the word blood thinner, sometimes it's a generic term. Well, to me, blood thinner would mean, the true nature of blood thinner would be Coumadin. But a lot of times people will use aspirin or clopidogrel or one of those antiplatelet drugs as a basket term for a blood thinner. The FDA states that after you get a coronary stent, assuming there's a stent treatment, you should be on clopidogrel or an antiplatelet drug for about a year, depending on the type of stent. Generally, with a heart attack, about a year. I routinely don't use blood thinners other than aspirin. I usually say aspirin for life if you've had a heart attack, and then all the other blood thinners I generally will stop unless there's an overwhelming reason to stay on it, because there is a bleeding risk associated with being on too much blood thinner, particularly as you get older. There's bleeding risk in the stomach. If you fall, hit your head, there's a bleeding risk. So I generally will use aspirin after the first year, and unless there's a reason to be on other blood thinners, I will stop it. Sometimes I'll use them if there's a lot of patient characteristics. But
Great. Anything to add to that? Or?
Not really. I think Dr. Mahruos answered the question pretty well, because I think what the patient's getting at is when they say blood thinners is probably aspirin and Plavix or aspirin and Brilinta or whatever, and that's really Dr. Mahruos' area of expertise, and it's generally thought that you should remain on at least 2 of them for a year after a stent or after a heart attack, and then after that, it's a little bit up to the discretion of the patient and the doctor, and whether what's their bleeding risk and what's their risk of having a subsequent cardiac event.
And of course, the best medicine is prevention, which brings us to this. We've just made it through all of the Christmas and New Year's get-togethers. The Super Bowl's on its way. Hopefully the Packers in Kansas City is soon to be here. Not to mention all of the regular birthdays or family reunions that roll around. There are many, many, many opportunities to overindulge throughout the year, but we know that we shouldn't.
With the holiday season upon us, there are many gatherings being planned where friends and family will gather for conversation, socialization, and of course, some food. If you are hosting a gathering, use these tips for a healthier menu. Substitute 2 egg whites instead of a whole egg to cut back on cholesterol. Use low-sodium, fat-free chicken broth instead of milk or butter to mash your potatoes. Substitute applesauce for oil, margarine, or butter in your baked goods. Use fat-free yogurt as a substitute for sour cream in dips and sauces. And choose reduced fat cheeses. If you're a guest, use these tips. Start your day with a high-fiber, high-protein snack. Don't starve yourself beforehand, rather have a small, healthy snack before going. Choose your foods carefully and have a plan. Don't rush to eat. Move your socializing away from the buffet or food. Take time to enjoy these gatherings and conversation that comes along with them. However, make sure you stay aware of your eating habits throughout each day and at each event. No matter the setting, take a moment before sitting down to eat to mentally plan a well-balanced plate. Decide on trying a few new foods and commit to sticking with a few healthier options as well. Also, only allow yourself 1 to 2 trips through the food line. Too many trips can mean extra calories. If you are asked to bring something, try a new and lighter recipe to share, such as fruit and low-fat yogurt dip or vegetables and low-fat dip.
So after you have a patient that comes to you and starts going through, do you ever work with a dietitian or that, or talk about their lifestyles? What they eat, exercise, things like that. Do you work in collaboration with that? As they go past?
Okay, so the diet and exercise and weight loss is obviously a huge issue in our population these days. So from a rhythm standpoint, there's actually a study that was done within the past year, getting right around the last year now, done out of Australia. They studied people for 5 years, and they found that if you lose 10% of your body weight and you can keep it off, not like you gain and then you gain and you lose and gain and lose, but if you lose it and you keep it off, that their ability to control atrial fibrillation with just the weight loss alone was comparable to what you get with an antiarrhythmic drug. Mm-hmm. But I found it's difficult to convince people to lose the weight because it takes time. You put the weight on over time, and you have to take time to get the weight off. It's difficult to do. But yeah, it's obvious. It's a very effective strategy, and I think that's something that everybody should do. And probably in addition to taking the medicine or doing procedures, is I always consider the weight loss.
Yeah. It always seems like on the show at some point it always comes down to eating better and exercising more, and takes care of so many things. So we've got one here, a 55-year-old woman from Sioux Falls. Do surgical stents ever break loose, migrate to other parts of the body, and cause trouble? And also, do stents wear out? And can you get another one in the same spot if one did not stop working or whatever?
So I'll tackle the first part. So do stents ever break loose? The reality is no, but once a stent is in place, it's not going to budge. It's embedded in the artery. The artery actually heals around the stent, forms a layer called the endothelium, and that stent's in place. It's not going to move. In some folks, I've had very rarely when you're actually implanting the stent, it comes off the catheter, and then you have to salvage, but that's very, very rare, inherently rare. But once the stent is in place, essentially it's there for good. Do stents ever wear out? That's a question I get occasionally. A stent really doesn't wear out. When the stent heals, it forms a layer of scar tissue around the stent. And if that healing process is normal, you're left with an open artery. What folks are asking is that, will the stent plug up? In some folks, a stent can plug up with scar tissue, and then you're basically right back where you started. So a stent doesn't wear out, but it can restenose while it heals, and that's sort of an unpredictable event.
And in the case that you're talking about where it might come loose while you're trying to place it, you wouldn't ever leave that. You'd always...
Usually what will happen is if it's a very calcified artery and it's very rigid artery and it's not very pliable, and as you're putting that stent in, it basically comes off the balloon. I think I've had that happen once in 10 years. It's a very rare occurrence, but it does happen, and when that happens, we end up having to basically essentially smash the stent with a balloon against the wall of the artery and just let it heal itself into place.
Wherever it ends
Wherever
up.
it's at, because you can't really
Move it.
pull it out. It's impossible to get that. So, but that's a very rare occurrence.
And and if that one did recalcify, can you replace another one in the same
You
spot?
can put
or-
a stent inside of a stent. Usually we'll use what we call a drug-eluting stent. The drug-coated stent has special chemotherapy embedded within the metal of the stent that prevents that scarring process, much less than older generation stents.
Okay. 72-year-old man from Sioux Falls. What's the difference between atrial fib and atrial flutter?
Okay, so I'm gonna go back to
Yep.
the drawing board here. And so atrial fibrillation and atrial flutter are on a continuum. They're very much related. We treat them a lot the same way. Atrial flutter is much more organized, though. Typically, the most common type of atrial flutter is your heart gets activated over and over and over again in this right atrium, around and around and around. Usually the atrial rate is somewhere in this 250 beats a minute range. All right? Now, atrial fibrillation is your heart's being activated from all over the place. Both atria are involved. The rhythm in the upper chamber is very chaotic, very rapid, very irregular, very disorganized. And then our target, where we think atrial fibrillation often is started, is over here in these veins. You see these little purple structures here, where they connect up to this left upper chamber of the heart. That's usually where we think atrial fibrillation is started, and that's where we go to ablate or burn when we try to, or freeze, if we try to get rid of the atrial fibrillation with a procedure.
61-year-old man from Sioux Falls. What would the average age of a person be when they would get a defibrillator?
It varies a lot in all the studies that were done, looking at the effectiveness of defibrillators. Patients were in their 60s. We do defibrillators in patients in their 80s even.
We have a woman from Spearfish. Her 50-year-old son snores excessively at night, and not sure if he has apnea or not. He says there's a flutter in his heart and it wakes him up. Is that something that could be related to?
I'll touch on this. So, in our population, folks with coronary disease, congestive heart failure, I always try to screen for sleep apnea. It is a very common, underdiagnosed and undertreated rhythm issue that can relate to a rhythm issue. It can lead to worsening heart failure, shortness of breath, fatigue, weight gain issues. Absolutely, if he's got periods where there's not breathing at night, your oxygen drops, that can be a strain on the heart, can trigger atrial fibrillation. Atrial flutter are often related to sleep apnea. Should get checked out if there's any question as to that.
And maybe keep you on board here. We have an 85-year-old man from Sisseton, has leakage of the heart, and was wondering if it would get better and heal by itself, or does he need surgery? Does that make sense?
Sure. So leakage of the heart to me would mean a valve leak. There's aortic valve, mitral valve, tricuspid valve. Those are the three main valves. There's a pulmonary valve, but that's usually an irrelevant issue. Leakage of the heart, oftentimes somebody will say you have a murmur, you have a leaking heart. Generally, surgery would only be needed if it was moderate to severe leaking, and if it was causing actual structural problems with the heart. There needs to be more information known about why is it leaking, what's the reason for leaking, and is it causing actual problems before you could make any comment on that.
An 88-year-old woman from Sioux Falls was wondering what she might do to prevent strokes, and obviously we're relating mostly from your area, from the heart. Is there anything?
Well, that's a broad question. In general, you have to live a healthy vascular lifestyle, which is, healthy diet like we reviewed there, exercise, that kind of thing. Keep your weight down, watch your blood pressure. If you have a lot of risk factors, or if we're finding that there's something going on with your carotid arteries, or if you're in atrial fibrillation, then we talk about prescribing medication for that kind of thing.
I would touch that in elderly. High blood pressure is a very common cause of strokes, so making sure your blood pressure is controlled adequately. And then atrial fibrillation is also a very common cause of strokes can go undiagnosed. So if there's any question as to rhythm abnormalities, making sure those are treated appropriately. But those would be the two areas to try to prevent stroke.
68-year-old woman from Winter, are stents pretty much the same for every patient, or do you have different sizes, different styles?
Well, a good question. Stents are, there's different manufacturers of stents. They all come in different sizes. They can go anywhere from 2.25 millimeters up to 4.5 to 5 millimeters. They can be anywhere from 8 millimeters in length up to 38 or longer millimeters in length, or I meant diameter and then length. So no stent is perfect for every patient. It really depends on the size of the artery, the length of the blockage, and then there's different types of stents. We talk about drug-coated stents or non-drug-coated stents, and again, that's a decision that's made when you're with the patient. You know, if they say, I have surgery next month, I have to come off my blood thinners, you're not going to put a stent in that says you're going to have to take this for a full year, don't stop it for a year. So you have to ask sort of those questions beforehand.
There's also new like bioabsorbable stents coming out.
So there's a stent that has a polymer that degrades over time. It's supposed to have a less risk of restenosis and then a less risk of thrombosis or clotting, which has been the downfall of some of the stents over time.
Oops, I went past it here. An 87-year-old woman in Brookings is taking amiodarone, is that correct?
Yeah, amiodarone.
Amiodarone. That's even more fun to say.
Yeah.
Amiodarone. Suppose it's supposed to control heart rhythm. What are your thoughts? Is that usually successful?
Amiodarone is the most potent antiarrhythmic drug that we have. Sometimes you don't have too many options because if a patient has bad kidneys or if they've had heart attacks in the past, it really limits which other medications you can use. And if you've got other issues, you may not really be a candidate for an ablation procedure or some kind of invasive procedure. So I use amiodarone all the time. If you look it up on the internet, okay, you'll read all kinds of bad things about amiodarone because it does have a very real risk of toxicity. The primary ones would be your thyroid, your lungs, your liver. It can also deposit in your skin if you're on high doses, your retina.
What happens then when it starts doing that? What's
Your skin changes color. It becomes sort of this sort of pink, sort of lavender sort of color. And you don't see it very often. You have to be on very high doses for a long period of time for that to happen. But I think they used to see a lot more toxicity with amiodarone in the old days when people used a lot higher doses and weren't necessarily aware of all the problems, and they didn't have other treatment options that we have available today. But if you use amiodarone and you're monitored closely, it can be a safe drug to take.
and successful?
And successful, yeah.
Our 65-year-old from Alchester, are stents more often placed in women or men?
I wouldn't say that it's placed in one or the other more frequently. I don't know the specific data, but it's really based on...
Well, in your practice, is it really, do you think it's kind of 50-50?
Well, I mean, men tend to get coronary disease at an earlier age. So in men, it really starts to accelerate more around the age of 45. In females, probably more like 55. So if you were just to play an age, I would say men probably end up getting more treatment for coronary disease, which would include stents. Mm-hmm. But women come in with heart attacks, men come in with heart attacks. Women get angina or chest pain. I would say if you were to pin me down, I'd probably say men just because they get coronary disease at an earlier age.
Is that the same for pacemakers and things?
It's really variable for pacemakers. We'll see a lot of elderly patients with it's almost like your conduction system just starts to get corroded or something like that. It'd be sort of an analogy, but I've put pacemakers in people in their 30s. I've put pacemakers in people in their 90s.
What's the youngest person you've ever
put a pacemaker in their 20s? I'd say, yeah.
So did he have some sort of
heart
failure thing going on, or what?
You can have congenital problems. You can have issues where you had some kind of an infection that caused an issue. You can have autoimmune diseases where your immune system attacks your heart, stuff like that. Yeah.
Is any of this stuff genetically transferred? I mean, obviously there are genetics involved, but I mean, do you see that in families? Does it tend to run?
Typically, if you're putting a pacemaker in a young patient, there's something unusual going on in that case, and you have to really consider those things. Yeah.
The family doesn't get a bulk rate for buying pacemakers.
No.
What's the more? We've only got a couple minutes left here. So, what would be our takeaway here for you, for people? When do they need to start paying attention to things, or what should they do to avoid seeing you? Maybe.
I'm a very strong proponent of prevention. So once you start developing all the complications of heart disease, coronary disease, once you have a heart attack, heart failure, it's a lot harder to treat it and reverse it than it is to prevent it in the first place. But modern medicine has so many options now that if something were to happen, we can treat it and get you back to the same functional level that you were at before. So making sure you're exercising regularly, eating well, eating right, trying to, making sure your cholesterol is controlled, blood pressure controlled, keeping the weight down to prevent diabetes, all these things that over time lead to the chronic medical illnesses that are so common and cause so many problems. Trying to prevent that, I would say exercise regularly is probably the most important thing.
What do you all see coming down the road? Is there anything new that maybe you've read in the literature that's going to happen that you're excited about seeing?
So like I said, I'm in the techie field, right?
Yeah.
And
well, that's why I asked you this one, because I figured there's got to be some technology.
Yeah. So there's lots of really exciting things coming along. We already have, in the past, all the pacemakers and defibrillators where you shouldn't have an MRI scan and stuff. Now we've got devices that you can have an MRI scan with just about any device that we put in. We've got defibrillators that don't actually have to be implanted into the heart. Some go underneath the skin. We've got new pacemakers coming out where there's no can, there's no leads. It's just a device that gets implanted into the heart, and that's it. It's all contained within the heart. We have lots of new tools. We've got some devices coming out where we can possibly implant a little plug into a spot in the left upper chamber of your heart, so you might not have to take a blood thinner for your atrial fibrillation.
Well, that's great, and unfortunately, our show is coming to an end. And now for the winner of tonight's Prairie Doc question. The irregular heartbeat rhythm of atrial fib, or AFib, puts the individual at increased risk for stroke, and therefore blood thinners are almost always indicated. True or false? And I think we all know the answer here is true if you've been paying attention. It was Elaine Beta of Mitchell who answered the question correctly. Thank you, Elaine, for participating, and a book will be in the mail to you soon. We'll be right back after this.
You still feeling lousy, sweetheart?
Terrible. Day 4 of aches, chills, sweats.
Oh, poor thing. You're just not you when you have the flu.
I don't feel like me at all. Do I look sick?
You look different.
Oh, you're so sweet.
That's not your pretty face.
Feel like yourself. Get vaccinated, because stopping the flu starts with you.
The rhythm of life is a powerful thing. The universe is surrounded by repeating and recurring patterns or cycles. For example, Mother Nature brings about the day and night rhythm, the moon and tides, the seasons, and of course the cycle of living with birth, reproduction, and then death. But oh, the splendid rhythms of a normal human body. For example, there's the monthly menstrual cycle, the daily rise and fall of natural steroid levels, the regular rhythmic toothpaste tube sequence movement of the bowels, and the nightly sleep cycle, the rhythm of breathing, and of course the regular lub-dub beat of the heart, to name a few. The source for the heart rhythm comes from special natural pacemaker heart tissue that acts something like electrical wiring. Named the conduction system, these special cells wind their way through the heart, automatically firing some 60 to 100 times a minute to trigger the rest of the heart muscle to squeeze. This rhythm system knows to speed up when the sidewalk is being shoveled, the bed is being made, or even when that special girl asks for help carrying her books. The conduction system even knows to slow down and relax a bit when the body lies down to rest. The cardiac rhythm continues without interruption, without a break, from before birth till we take our last breath. But sometimes things can go wrong. There can be a short in the wiring, and then the heart suddenly beats too fast. Or a complete break of conduction can occur, and then there's no rhythm or beat at all. Thankfully, we have a new kind of body electrician called an electrophysiologist, a cardiologist, to fix these problems. She or he uses medicines or an implantable defibrillator when the heart goes too fast, a pacemaker when the heart goes too slow. And we depend on this expert to help us know when the timing is right to do nothing and let nature take its course. The rhythm of life is a powerful thing.
A heartfelt thank you to our guests tonight, Dr. Jonathon Adams and Tarik Mahruos. Their experience and insights were invaluable to the show. The South Dakota World's Affairs Council has chosen global health as its annual symposium theme. The symposium will be in January 28th and 29th in the Volsdorf Ballroom of the Student Union of the South Dakota State University campus here in Brookings. The symposium is free and it's open to the public. For additional information about the speakers and their topics, visit southdakota.worldaffairscouncil.org or call 691-2687. This will be a wonderful event with some great, knowledgeable presenters. You will not regret attending. And now to our flu season update. We're doing much better than we were last year at this time, but we're not out of the woods just yet. In previous years, when we started out with a few cases, the peaks still went very high, though they were delayed to maybe March or even April. Do not delay in getting your flu vaccine now. It'll reduce your chances of catching the flu bug. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, remember to exercise your heart every day, physically and emotionally. Good night.
It can be a seasonal allergy, viral or bacterial in its cause, but it is always miserable. How to deal with congestion. Next time, On Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, the Avera Heart Hospital, Brookings Health System, Dakota Allergy and Asthma, Dakota Care, Orthopedic Institute, Physicians Care, Sanford Clinic Community Service Committee, Swiftel Communications, and Vance Thompson Vision. Closed captioning for On Call with the Prairie Doc is provided by Avera, Brookings Health System, and the Fishback Financial Corporation.